Hi, welcome to the Neonatal Cardiac Curriculum Series. My name is Sean Sen, and today we're going to be talking about neonatal arrhythmias. I have no conflicts or disclosures. The goals for this lecture are to review the normal and abnormal ECG parameters in a healthy newborn. We'll review and identify the most common types of bradyarrythmias seen in neonates, and then understand the differential diagnosis for both narrow and wide complex tachycardia. And while we do that, we'll review options for neonatal treatments for tachyarrhythmias as well. So this is a quick review of an ECG waveform. There's the P wave, which represents the electrical activity of the atria as they depolarize or contract. Then you have the QRS complex, which is the rapid depolarization of the ventricles. And then the T wave, which represents the repolarization or relaxation of the ventricles. In here also you have the PR interval, which will measure the time between the onset of the P wave and the beginning of the QRS complex. Typically we look at to see if whether or not this gets prolonged or if there's a delay in that electrical conduction through that AV node. The ST segment is this isoelectric or flat section between the QRS and the start of the T wave, and typically elevation or depression can indicate some sort of ischemia or reduced blood flow. And then the last one is the QT interval, which represents the duration of the entire ventricular electrical systole. And so this is both depolarization and repolarization. And typically this interval, if it's prolonged, it's associated with certain types of arrhythmias, especially if it gets too long, where you have something called an R on T phenomenon. And we'll talk a little bit more about that. So a typical ECG has 12 leads, 6 of them which are limb leads and 6 of them which are precordial or chest leads. If we look at the limb leads, they're really made up of 3 bipolar limb leads. And so one of them that's in the right hand, the left hand, and typically the left foot, and denoted as leads 1, 2, and 3. Each limb has 2 electrodes, a positive and a negative one, so each one is called a bipolar limb lead. And if we moved those to intersect at a certain point, you can create a 360-degree directionality of each of these positive electrodes moving in 1, 2, and 3. Now, additionally, if each of these limb leads, the right, left, and foot, are measured individually while grounding the other 2, we can see that there's 3 more additional augmented leads. And these were originally called augmented leads because they needed to amplify the voltage in order to record it. And so what ended up becoming is each of those leads became augmented voltage left, augmented voltage right, and augmented voltage foot, or AVL, AVR, and AVF. And so when you add the original 3 limb leads plus the augmented leads, you have 6 intersecting limb leads on a standard EKG. So the electrical activity always remains constant, but these positive electrodes change from lead to lead. And so tracing that looks slightly different based on the angle that we're recording. And so a typical wave of depolarization is positive, charges passing through the myocardial cells. And so when that depolarization happens, it moves towards the positive end of that electrode. And so if we see that moving in the same direction, we should see an upward deflection of the EKG. And then if the depolarization is moving away from that positive electrode toward the negative electrode, we should see a downward deflection. And I liked this analogy from Dubin's book, Rapid Interpretation of EKGs. But when we look at a ECG access, really what we're seeing is that there's many different camera views of this car, for example. And so what we're trying to do is, although we could see it in from one plane, having multiple different planes can give us a much better picture of a 3-dimensional structure. And so similarly, those 6 limb leads are really those 6 angles looking at that heart and trying to look at what that electrical activity looks like. Lastly, if we talk about grouping these limb leads. Sometimes if we group the left hand or lateral leads, that would be 1 in AVL, so that the positive electrode is going towards the left arm. And then if they're going down towards the foot, those would be primarily 2, 3, and AVF. So when we look at this in a planar view and we look at a cumulative direction of positive electrodes, when we think about a contraction or depolarization, the general direction of the electrical activity is in this direction. And so what we would see is a positive deflection in 1 in AVL. We would see a positive deflection in 2, 3 in AVF, and we would see a negative deflection in AVR. And that would be your typical movement in a contraction. So a typical newborn will have a heart rate of an average of 110 to 160, and within normal range can anywhere be really from 90 to 220. A typical PR interval is about 70 to 140 seconds, and anything greater than 140 would be considered prolonged. It's best taken in lead 2. And your QRS axis typically is under 180 degrees. For preterm, it can be between that 65 and 174 degrees. And your QRS interval really shouldn't be greater than 80 milliseconds. So how do we determine a QRS axis? So here we have a 2-day-old term infant, and let's put up our axis wheel. And we can see over here in lead 1, it's generally a negative deflection there. So it's somewhere in this half of the spectrum of that axis. And then if we looked at AVF, it's up in AVF, and so it would be positive. So it's somewhere in this right axis here. And so what this would be considered is a right axis deviation or a right axis QRS. And it's actually pretty typical for a 2-day-old term infant, mainly if they have in the presence of right ventricular hypertrophy, and as they're transitioning and that RV is relaxing, sometimes those rightward forces can cause a more of a right axis deviation. What about this QRS? Here in lead 1, it's positive, so generally it would be in this hemisphere of the wheel. And then in AVF, it's pretty isoelectric, but somewhat negative as well. And so in this case, what we see is a more of a left axis deviation or a superior axis deviation. And so typically, superior axis deviation is an abnormal finding in neonates. Think congenital heart disease here. Because of these lack of right-sided forces, it pushes the entire QRS axis above the lateral leads, and so the typical lesions that we see would be tricuspid atresia. If you're missing sort of the crux of the heart in AVSDs or AV canals, and then also in large septum primum ASDs. So this is great for the boards and understanding the concept why electrical forces would be normal and abnormal, but the reality is in clinical practice, if we're looking at a diagnosis, I think if they're asking for a next best step, would be to confirm the diagnosis would likely be a echocardiogram. So let's briefly talk about the QT interval. Because the QT interval changes with heart rate, the QT naturally is prolonged at slower heart rates and is shorter at faster heart rates. What we do is we measure a corrected QT, which estimates the QT interval at a standard heart rate of 60 beats per minute. There's many different ways to standardize it. The most common is Bazette's formula, which is the QT interval divided by the square root of the preceding R to R distance. It's typically best done in leads 2, but you can also look at your chest leads V5 and V6. And it's, typically you measure that preceding R to R interval, not any other R to R interval. The classic, the average QTC for a term infant is about 400 plus or minus 20. And when we look at a normal distribution, 2 standard deviations would be about 440 milliseconds. And so females tend to have a little bit of a longer QTC than males, and preterms generally have a little bit longer QTC than term infants. Mild QT prolongation, so in that 460, 470 area, may be normal, and the expectation is that they would normalize by 2 months of age. The problem is that you have a normal distribution of infants who have a typical QT, and then you also have long QT syndrome. And so what is difficult sometimes to differentiate in neonates is this little overlap between the two normal distributions. And so this is the patient population that we have to watch closely to determine whether or not will they develop long QT syndrome. And so if you see long QT in the neonate along with symptomatic bradycardia, those two are highly suspicious, as well as a family history. A little bit about long QT syndrome. It affects 1 in 2,500 infants. It's typically inherited in an autosomal dominant manner. And the biggest risk is developing fatal ventricular arrhythmias, polymorphic VT or ventricular tachycardia, also known as Torsades de Pointes. It's really a channelopathy. It's typically associated in both the sodium, potassium, and calcium voltage gated ion channels. And about 10% of these long QT syndrome gene variants have been associated with sudden infant death syndrome. A family history, typically in a follow-up screen at 2 months, should be made for any neonate that has a greater QTC greater than 470, along with symptomatic bradycardia. So let's talk a little bit about what determines a sinus rhythm. And so if we look here, typically what we do is we want to make sure a sinus rhythm comes from the SA node. And so we're really looking at the P waves to say, are these P waves coming from the SA node? And so looking at our axis wheel here and looking at the direction and deflection of the P waves. So here you could see in leads 1, the P wave is up. And so it's in that positive direction, and it's up in AVF, and it's down in AVR. And so if we look at that wheel, the direction of the SA node going down the atria would be in that direction, where it would be positive in 1 in AVF and negative in AVR. And so this is how we would determine whether or not a P wave or whether or not we're seeing a sinus rhythm. Additionally, we also need to make sure that there is a P wave before every QRS and that there's a QRS after every P wave. PACs, or premature atrial contractions, have a different morphology than the sinus P wave. And so the P wave may be conducted through the ventricle, so you see the QRS, or it may be during a refractory period and the P wave may be completely blocked. Typically, when a premature contraction does happen, there's usually a compensatory pause afterwards for the entire heart to reset, and then the sinus P wave comes through again. And so PACs that occur in a bigeminal sequence, so this would be a normal QRS through the sinus beat, followed by this early premature atrial contraction that gets conducted, followed by that compensatory pause, results in this typical pattern, and we call that atrial bigeminy. This is an example of a PAC that's a blocked PAC, and so the black arrow shows you where the P wave is. And you can see that there was no QRS conducted through, followed by that compensatory pause, and then it resets. And so if you have a series of blocked PACs or a blocked atrial bigeminy, this can present as a symptomatic bradycardia, because you have a QRS followed by a blocked PAC, followed by that reset, followed by that QRS. And so on the telemetry, you would only see the QRSs, and this would show up as a severe symptomatic bradycardia, but in reality, all it is just a blocked atrial bigeminy. PVCs, or premature ventricular contraction, are defined by a broad QRS, so greater than 120 milliseconds. Typically, it's 2 times the R to R interval, and they can be multifocal or unifocal. And really where this is again a ventricular contraction coming from the ventricles that result in a depolarization of the entire ventricles. For nomenclature, if we see every other beat being a PVC, we would say ventricular bigeminy. If we see every other third beat as a PVC, then that's ventricular trigeminy or quadrigeminy, depending on how many beats the PVCs are. Consecutive PVCs are a little bit more ominous. Two PVCs are called couplets. Three PVCs are called triplets. And four PVCs are really now to the point where we call that non-sustained VTAC or ventricular tachycardia. And so anything greater than 4 to 30 consecutive PVCs would be considered non-sustained ventricular tachycardia. And if you have more than 30, then you just have sustained ventricular tachycardia. And as a provider, it's important to document or helpful to communicate with your pediatric cardiologist to describe what that VTAC looks like. And so what's helpful is the number of beats, the rate, whether it's monomorphic or polymorphic, whether or not there was symptomology or hemodynamic compromise, and whether the patient showed any signs of stability or instability. Okay, now we're going to review a broad overview of neonatal arrhythmias. And so if we think about it into two categories, bradyarrythmias, which really involve sinus node dysfunction or AV node dysfunction, and tachyarrythmias, which really we can narrow it down to narrow complex or wide complex tachycardia. So sinus node dysfunction is a broad terminology, but when we talk and define about sinus bradycardia, in the first week of life, it's defined as anything less than 90. In the first month of life, it's anything really less than 100, 107. When we look at sinus pauses or sinus arrest, this is typically the sinus node failing to trigger a contraction. And so because of that, there's no electrical activity, or if there's that brief pause, you don't see anything conducting, except sometimes you may see a backup escape junctional rhythm or even a ventricular rhythm. And typically a sinus pause or an arrest can be normal for up to 1,000 milliseconds. It's helpful not to, when you do talk about these sinus pauses or sinus arrests, not to call it asystole, as asystole has a connotation that's associated more with a pause or arrest in sinus activity that's associated with cardiac arrest, whereas sinus pauses or sinus arrest are usually meaning that there was recovery of that rhythm. So here's just a differential, a broad differential for causes of sinus bradycardia. The most common seen in the NICU may be due to oversedation, high vagal tone, increased ICP, hypothyroidism, hypothermia. Conjugated hyperbilirubinemia is interesting. It's due to elevated bile acids in the bloodstream that disrupt the normal electrical conduction in the heart, and so you have slowing down of the SA node. AV node dysfunction is really broken into 3 degrees. First degree is a misnomer. It's really just a prolonged PR interval, often due to a high vagal tone. A second degree AV block is broken into 2, Mobitz 1 and Mobitz 2, which we'll talk a little bit more about. And third degree is complete heart block. Second degree AV block, or Mobitz 1, or sometimes known as Winky block, is a progressive lengthening of that PR interval with occasional non-conduction to the ventricle. And so this is it's not pathologic. It often occurs during deep sleep in neonates, and it's a normal finding. And so if you do see this, it's usually attributed to a high vagal tone. No further cardiac workup is usually needed if it's isolated. So, second degree AV block or Winky block can be associated also in our post-op neonates who undergo cardiac surgery. Typically, it's related to the swelling around the AV node. Again, here the no intervention would be necessary. The PR lengthening can be very subtle, so it's important to measure these with calipers either on a 12 lead or through the telemetry. But the PR lengthening doesn't have to occur with every QRS. It just has to be a gradual. And then the first conducted QRS after a non-conducted P wave should finally have a shorter PR interval that shortens back to its original length. Mobitz 2 AV block is a little bit more concerning because it reflects distal conduction system disease, and it has a high risk of developing complete heart block. What you see is typically dropped QRS with no PR prolongation, and they can occur really in any part of the rhythm or successively, as you can see here, where you lose all QRS completely for a brief period of time, and then you start back up again. The best way to describe this is really imagine a phone charger that's starting to fray. And what you're seeing is that sometimes it's conducting, sometimes it's not, and it's kind of very finicky. And what's ultimately going to happen is that it puts it at a very high risk for that entire charger to just stop working entirely. And once it does, then you develop that complete heart block. And so sometimes you can see it in the postoperative period that may resolve, but generally we're talking about a treatment with a pacemaker. Lastly, third degree AV block or complete heart block is a phenomenon that, again, is complete disassociation with the at the AV node level. And so your P waves are beating independently, essentially, from your QRS. And the etiologies here are what's usually most likely tested upon in neonatal boards. You think about congenital complete heart block that's related to maternal lupus. That's your anti-Ro and anti-LA antibodies. You can see it after post-op heart block, after typical VSD or AVSD repairs. There's degenerative conduction disease like Kern-Sayre, as well as certain congenital heart disease that are L-looped. For example, congenitally corrected transposition or LTGA have a higher risk of developing complete heart block. And then lastly, you can also see it from an infectious etiologies like Lyme disease. So the definition is complete AV dissociation. So the atrial rate must be faster than that ventricular rate, so more P waves than QRS. And your ventricular escape rate should be regular and completely disassociated from the P waves. So let's look at this example. You have a 4-month-old female says post a VSD closure. And if we look at lead 2, you can see that there are the QRSs, which are marching along independently. And then also you have these P waves that are marching along independently as well. And so each of these P waves are not conducting appropriately, and so these are completely disassociated, and this would be an example of complete heart block. This is a quick review for indications for permanent pacing. Typically, it's if you see that advanced second-degree Mobitz 2 or third-degree AV block that's associated with symptomatic bradycardia, ventricular dysfunction, or low cardiac output. And then post-op period, if you see Mobitz 2 or third degree, that's not expected to resolve after 7 days, can be considered for a pacemaker placement. And this comes from studies that looked at what the percent of recovery was seen after post-op day 7, which was about 50%, and by post-op day 9, 97% of those that should recover would recover by 9 days. Okay, so we're going to switch over to tachyarrythmias, and the best way to think about this is to break it into two types. There's narrow complex tachycardia or supraventricular tachycardia, or wide complex tachycardia, which are coming from the ventricles. So what is SVT? Well, according to Wikipedia, it's an abnormally fast heart rhythm arising from the upper part of the heart. Medscape defines it as a episodic condition with an abrupt onset and termination, requiring atrial and or atrioventricular nodal tissue for its initiation and maintenance. And, if you look at really what SVT is, there is some truth to both of those definitions. But it's a narrow, complex tachycardia that originates above the AV node. And so, therefore, it must have the same QRS morphology during the sinus rhythm. There are some exceptions, but that's generally what we look for. SVTs are generally seen in a bimodal distribution. We can see it in infancy as well as adolescence. About 40 to 80% of infants outgrow SVT by 1 year of age, and those that are more persistently tachycardic are usually seen in more in the adolescent population. If we looked at the incidence of SVT, particularly in the neonatal and infant population, if you were to play a numbers game, a majority of them are usually accessory pathway mediated, followed by a small portion that's AV-NRT, and about 10% are flutter, and usually the 5% tend to be some sort of ectopic atrial tachycardia. So the steps to diagnose tachyarrhythmia. So we talked a little bit about the two broad topics of narrow and wide. And when we look at the different types of narrow complex tachycardia, the two categories we can break it into is regular rhythm or irregular rhythm. And so those would be whether it's a regular rhythm that's reentrant or a irregular rhythm that would be automatic. So let's talk a little bit more about the automatics. Automatic tachycardias really revolve around something called automacity. Automacity is defined as the ability of the heart cells to spontaneously depolarize and generate an action potential. So what that means is, in addition to the sinus node, which fires automatically, every cell in the heart has the capability of spontaneously depolarizing and acting like a sinus node. And so when we see these automatic tachycardias, what they are is really those other cells from some other location that's firing away now, and that's taking over the heart rate. And so the classic way to find this would be to look for non-sinus P waves. If it's a single source, it's an EAT. If there's multiple different sources, it's MAT. And then if it's coming from the AV node or near the AV node, it would be a junctional ectopic tachycardia. So EATs, or ectopic atrial tachycardia, are increased automacity of one or two non-SA node focus. It can lead to dilated cardiomyopathy if it's not recognized. You typically see it in older children. And if it doesn't present in tachycardia, then it's called an ectopic atrial rhythm. If there's more than 3 automatic focus, that's called multifocal atrial tachycardia. We actually see this more commonly in the neonatal population, particularly with respiratory illness. So the classic story is either with a pneumonia or with BPD, chronic lung disease. And if it's not tachycardic, but you're seeing multiple different P wave morphologies, and that's called a wandering atrial pacemaker. So let's look at this rhythm. If we see on our wheel and we look at the P waves, in leads 1, it's up. In leads AVF, interestingly, it's down. And in leads AVR, it's up. And so this is actually the direction that we're seeing this P wave coming from, and which is different than your typical SA node. Which would be in that downward direction where it's up in 1 and AVF and down in AVR. And so this would be an ectopic atrial tachycardia. Multifocal atrial tachycardia is again mentioning that there's 3 different morphologic P waves that are seen. And so here you can see the different P wave morphologies for each of those beats. And again, classically, we see this with lung disease in neonates associated with either pneumonia, chronic lung disease, or BPD. Treatment for EAT or MAT, rate control is really the key here. And so a first-line treatment is usually with a beta blocker. Automatic rhythms are usually more affected by sympathetic tone. Flecainide works well with MAT, but there was a study that showed that it may be cautiously used in heart failure, congenital heart disease. And if your beta blocker or FLEC fails, you could also consider sotalol or amiodarone. JET is a fairly common phenomenon that's seen in the CVICU. It originates from the AV junction or the His, and it's commonly seen in our post-op patients with VSD repairs or tetralogy of Fallot repairs. And again, it's considered an automatic tachycardia, so there's a warm-up and cool-down, and it's not just a immediate brief on, brief off. And there is AV dissociation. So we see more QRSs than P waves. You can see it by this rhythm below. The treatment for JET, first line is to cool and sedate. Also, things to do along those lines is to avoid or reduce inotropes. You can use, if you have pacing wires, to atrial overdrive pacing. Treatment for this from an antiarrhythmic standpoint would be amiodarone or procainamide. Precedex or dexmedetomidine has also been shown to, if used empirically or prophylactically, has shown to help reduce the incidence of JET postoperatively. Okay, let's move on to regular rhythm or reentrant tachycardias. Unlike automatic tachycardias, reentrant tachycardias are abrupt onset and terminate abruptly as well. And so there's no warm-up or cool-down period. It's you were normal sinus beat, and then out of nowhere, you now are at a very fast fixed rate typically. And so that's the classic regular SVT or reentrant tachycardia. And what this is usually mediated by some sort of circuit or accessory pathway or some sort of reentrant circuit that develops, which causes a tachycardia. More for nomenclature, but types of accessory pathway-mediated SVT. The most common here would be atrioventricular reentrant tachycardia, and so you have an accessory pathway between the atria and the ventricles. If it moves in the normal fashion, it's called a orthodromic reentrant tachycardia. There's also something called a PJRT, which is a misnomer, but we don't need to go through that. Orthodromic is, if we break it into the two different words, it's traveling in the normal direction of a nerve fiber or conducting impulses in the normal direction. Ortho, which means straight or correct, and drome, which means running a racing track. And so typically I think about a racetrack where you're running in that typical normal fashion. And from a AVRT perspective, ORTs are essentially going down the normal pathway of the AV node through the bundle of His, down the ventricles, but there's an accessory pathway somewhere in the periphery that results in a retrograde flow of conduction up the accessory pathway back into the atria, back into that AV node. And so what you see is a normal direction, but a circuit that involves the atria and ventricles. So accessory pathways can be unidirectional or bidirectional. If it's unidirectional, it's considered a concealed accessory pathway because there's no way for us to know what that would look like from a conduction perspective. And so if we develop a tachycardia, then we know that there is a concealed accessory pathway because of that reentrant ORT that would see it. And typically, classically for these EKG findings would be a retrograde P wave after the QRS. However, accessory pathways can be bidirectional. And so if it's unidirectional, it's an ORT. But if it's bidirectional, and let's say you have a SA node that's conducting through the AV node, but then also integrate through that accessory pathway, what you see is a widened QRS and a shortened PR interval. And so this is what would be also known as Wolff-Parkinson's White. And so it's important then to always get a 12 lead, especially if you're coming out of SVT or if you've came out of SVT, to check to make sure that there's not a accessory pathway. And the way to check for that would be to see if whether you have a delta wave and a short PR interval. Again, characteristics of an ORT, there are typically retrograde P waves not buried within the QRS. Aberrant conduction is not uncommon. And about 25% of patients with ORT will have a bidirectional accessory pathway with evidence of pre-excitation on a baseline EKG or Wolff-Parkinson White. And lastly, there's an association with Epstein's anomaly and ORTs. AV NRT or AV nodal reentrant tachycardia are typically more seen in the adolescent or adult population. There are more females than males in terms of its incidence, and it's not usually associated with any congenital heart disease. There are generally two types of AV-NRT, typical, which is going down the slow pathway and then up the fast pathway, which is about 80%. Atypical is antegrade going down the fast pathway, and retrograde would be up the slow pathway, and that's usually about 20% of them. We won't touch more into details about this because generally we don't really see it in the neonatal population, but just know that it is a reentrant tachycardia that's located inside the AV node. Treatment for reentrant SVTs, if stable, you can give adenosine, which can be both diagnostic and therapeutic. It's helpful to have a continuous rhythm EKG if possible when giving adenosine. If we're unstable, cardioversion would be the right choice. And you could also, again, think about atrial pacing if you have pacing wires, or through an esophageal probe even. Medications, typically beta blockers are, again, your first line. If you're needing a continuous infusion, esmolol would be a choice. And then if refractory, you could think about other medications like procainamide, FLEC, or amiodarone. Lastly, about 10% of SVTs in newborns can be atrial flutter. And so this is a reentrant tachycardia that is not an atrioventricular tachycardia, but a circuit that is all up in the atria that end up firing into the AV node. And so these flutter rates can be up to 400 to 500 beats per minute, and it can be common in neonates. But of course, the AV node can't process all those 400 to 500 beats. Instead, it may be a 2-to-1 or a 3-to-1 or a 4-to-1 conduction through that AV node. So here's a 1-hour-old infant after placing a UVC line, and you can see the magnified view of the tachycardia. You give adenosine and you uncover this type of pattern. And so this is the classic example and the sawtooth pattern that you see after you've given the adenosine, which shows the successive P waves. And so the treatment here would be cardioversion. There are some medications that you could consider, like amiodarone and DIG, but generally the treatment here, whether you're unstable or stable for aflutter, would really be cardioversion, synchronized cardioversion. And for incessant flutter, you could think about sort of these bigger agents like sotalol or amiodarone. And lastly, aflutter can sometimes be triggered from a deep central line placement, or if it's all the way into the atrium and it's tickling one of the sides, and that might actually elicit the flutter response. So hopefully now we've gotten our broader differential for both reentrant tachycardias and automatic tachycardias. And we talked about adenosine for the treatment for some of these SVTs, but a little bit more in details. Adenosine has a half-life about 6 to 10 seconds. It works by pushing the potassium current outward. So this prevents conduction through that AV node briefly for that period of time. And it's helpful to appreciate the pathway of when we're administering adenosine. And so if we think about it, if we're giving it through a PIV, it goes to the vein, then back to the right atrium, the right ventricle, then goes to the pulmonary artery, the pulmonary veins, back from the lungs. It gets into the left atrium, the left ventricle, and then out the aorta. And then goes into the right coronary artery, and in about 80 to 90%, the AV nodal branch comes off the RCA, and finally gets into the AV nodal tissue. And so you can imagine when you're injecting or administering adenosine, this has to make it all the way to the AV nodal branch in under 10 seconds. And so it's helpful to, when you're administering this medicine, to use an upper arm PIV and to push it very quickly, followed by a normal saline bolus. So let's go through a couple of scenarios. You give adenosine and this happens. There's a complete pause, and then immediately it ramps right back up to an SVT. And so this would be an example of a ectopic atrial tachycardia, because all you've done is you've just blocked the AV node, but you haven't really blocked that ectopic automatic focus. And so right when it goes away, there's no conduction, but then it ramps right back up to SVT. There's a complete pause, and then it goes, you've converted back to a sinus rhythm, and you reveal that there's a short PR interval with a delta wave. And so this would be an example of a reentrant tachycardia, or an ORT, which has a bidirectional accessory pathway, or also Wolff-Parkinson-White. And this was not only diagnostic, but also therapeutic, where adenosine was able to break that circuit, and we were able to return back to a sinus rhythm. So we give adenosine and we have loss of QRS, but then now we see persistent P waves. And so this would be an example of atrial flutter. So this is uncovering that sawtooth pattern after we gave adenosine, because again, we've blocked off that AV conduction, no conduction through the QRS, and then now we see the successive P waves. You give adenosine and SVT continues during the entire administration. And so what this usually is that it's an insufficient dose. And so the typical dose is 0.1 mg per kg per dose. You could think about giving it either faster or doubling the dose to 0.2 mg per kg per dose. And that usually might be the better choice. Moving on to wide complex tachycardia, again, we won't spend a lot of time in here because 80% of ventricular tachycardias are really seen in the adult population. And in pediatrics, the differential here is, either it may not be coming from ventricular tachycardias, but really sort of other sources. So SVT with aberration. So if there's a bundle branch block, that can present with a widened complex tachycardia. There's antidromic reentrant tachycardia, which is the opposite of ORT, so it's going in the opposite direction. There can be nodoventricular connections, so these are accessory connections between the AV nodal tissue, His, or the bundle branch to the ventricles. You can have a flutter with pre-excitation, so this would be an a flutter that's going through a accessory pathway that can go both bidirectionally. And then about 20% of them are truly coming from the ventricular source and causing ventricular tachycardia. So again, in neonates, the differential diagnosis usually is 1, it could be ventricular tachycardia. 2, it could be SVT with aberration. So if you have a right bundle or a left bundle branch block, that results in a widening of that QRS, even though the SVT is coming from above the ventricles. And then lastly, if there's pre-excitation related tachycardia, so you have this accessory pathway that's bidirectional, and either through antidromic reentrant tachycardia or some sort of atrial tachycardia with pre-excitation. And then lastly, you can also see sinus tach with a baseline history of bundle branch block. So we have a neonate that presents with wide complex tachycardia. And during the fetal echo, they showed this. And so this is related to a cardiac tumor. And so these were rhabdomyomas that were seen from fetally. And it's, again, pretty infrequent, but one of the first initial presentations could be because of these cardiac tumors that are residing in the ventricles can result in ventricular tachycardias as their first presenting symptoms. All right, so hopefully we've gone through all the steps to diagnose the etiology of a tachycardia. Again, trying to differentiate between narrow complex and wide complex, and then if it's a narrow complex, to think about it in terms of whether it's a reentrant or automatic. And that's all. Thanks.